Good evening, friends. Uh, Dr. Anand Joshi on this side. This is the third talk in the series of lectures on the infectious diseases. Today's topic is a bit big, and as you guys must be knowing, I'm going to talk about tuberculosis. And tuberculosis is a huge and vast topic. Initially, I wanted to cramp the whole thing into the one. But then as I was going through, given that this is not, this is more of an MRCP examination, I thought some detailing is required. And by the time I reached to this detailing, I had already finished this 26 to 27 slides. So in the today's talk, I'm going to go through the initial introduction to the tuberculosis, bit of an epidemiology. It's a presentation. It's a type of tuberculosis which you should know, diagnosis, and the overview of the drugs. Uh, because the regime, drug resistance, special situation itself is a big topic, I will be going to talk about it in the second part of this. I hope this is okay, because too much of overloading will also be tiring for you guys, I guess. Am I right?
Yes, sir.
Yeah. And one more request, guys. Please try to be a bit more interactive. That will give me a bit of a assurance that everybody is awake and not just logged in and gone to sleep. So I'm just going to go share my screen. And everybody is able to see.
Yes, sir.
I need to get this. How do I get rid of this thing? Anybody can help me? Okay. Yeah, that's fine. That's fine. Got it. Got it. Okay, so today's topic will be Mycobacterium tuberculosis, and I would love people interact a bit more. How do you guys know that Mycobacterium tuberculosis have lots of cousins? Anyone? So we know that there is a Mycobacterium tuberculosis. Yeah, Shantanu? Anyone? Please get. I mean, it's like fourth, fifth lecture now. We should be talking more. Yeah. So if you look at the mycobacteria as a species, we are aware that there is a Mycobacterium tuberculosis and there is a Mycobacterium non-tuberculosis. But this Mycobacterium tuberculosis, it's a complex itself, where we come across a variety of Mycobacterium tuberculosis, in which MTB itself is one, and then we have later Bovis african, Capri, Canati, Micromungi, and Orges. These are all form part of the complex. However, the reason we don't study much about them is because they seldom cause any public health issues in humans. When we come to the non-tuberculous mycobacteria, so they are still important. We have Mycobacterium leprae, we have a leprosy, we have a lepromatous leprosy, which would cause a human disease. Then we have MAC, Mycobacterium avium complex. We have Kansai, Mariam, Xenopi. So all these microorganisms are not very common. However, with the advent of in about 30 years ago, with the HIV coming in, their importance started growing. Over the period of time, after HIV has left, we are now seeing or be cautious about in a solid organ transplant, bone marrow transplants, lung transplant, and then subsequent immunosuppressions. And these people are coming up with their ugly heads up. So from a human point of view, this becomes an important guide. When it comes to the Mycobacterium tuberculosis, so Mycobacterium non-tuberculosis, I'm going to leave it now. We will do it in the next session. For Mycobacterium tuberculosis, the primary host reservoir is the humans and situated worldwide. Bovis, as its name says, it's mainly in the animals, particularly in cattle. And we do, just give me a second, guys. Yeah. So we have this Bovis BCG, where we use a BCG vaccine. Then we have other ones in a primary host reservoir as a goats, rodents, sea lions. So African canity, Bovis BCG, and tuberculosis are the one where you will find it in the humans. Yeah. Now, tuberculosis is one of the oldest disease. Apparently, they say that before the humans, it existed. So we can fairly get assured that if we think that we can eradicate tuberculosis from the world, then probably we are daydreaming. Because if some organism, if it has survived all the ice age, bronze age, and dinosaurs, it's unlikely that we are going to destroy it. Yes, but we can try to control it, especially it being transmitted from human to human. Just 9195073. So it's a slowly growing organism. Its generation time is approximately it's almost 20 hours. So one of the important thing which we need to understand here is if we try to culture this organism, then it's going to take a long time. And again, with the given conditions, it may not grow early, right? So this becomes an important point. We have an organism which is infectious to the human, and you can grow it in the culture, but it's going to take a long time. Now, coming to the identification of this organism, most of the time when we talk about a bacteria, we talk it about a gram positive, gram negative, which is what we saw in our first talk. But these are the organisms which are gram neutral. So how we would we recognize them? So there is another stain which is called a Zeal-Nielsen stain, and when they tried to clear it with acid, they couldn't, and that's what it gave its name, acid-fast bacilli. Bacilli is because they are like rod shape. These organisms need oxygen. Again, they are obligate aerobes. So in the sense, if oxygen is given to them, then they grow very fast. But if in absence of oxygen or less oxygen, they won't die, but they will stay normal. Now, why this point is important? This will tell us why tuberculosis is commonly seen in the epices, where the perfusion oxygenation ratio is less. So there is a plenty of oxygen available. There is a less of the blood to uptake, so they can proliferate there. Why about we need to know about the obligate anaerobe? Obligate aerobe is that they remain dormant for long period of time inside the granuloma where the oxygen is less. So they can resist that. There is a resilience. Hence, it's an obligate aerobe. So now we know it's an acid-fast bacilli. It needs an oxygen. Now, when it came to acid-fast bacilli, it was also discovered that Nocardia, Rhodococcus, Legionella macdadi, and protozoa like Isopora and Cryptosporid. This 1, 2, 3, 4, and 5. These 5 other organisms are also acid-fast. The nearest differential, if you are asked about the acid-fast bacilli, is a Nocardia and Rhodococcus as in bacteria, or a Legionella macdadi, not all the other Legionellas. So this is the Mycobacterium tuberculosis for you. Epidemiologically, it is a public health. WHO and all other government, including Indian government, spend billions of dollars for that, and it is said to be a disease of the third world country or the poor country. Well, it's not true, but it's been labeled. So that's particularly because of the high prevalence, almost 95% in Asia, Africa, Middle East, and Latin America. Asia, when they talk about the Asian subcontinents, they are essentially talking about Pakistan, India, Bangladesh, and China. Epidemiologically, over last so many decades, there is a rising MDR, XDR, and tuberculosis. Particularly, it is associated, the importance went up with HIV, poverty, and overcrowding. Now, there are different steps where this infection becomes important. One is you get exposed to the bacilli and you get infected. Now, infection doesn't necessarily mean that it has manifested its problems, which we call it as a disease. So the first step is exposure to infection. Now, exposure to infection is anyone who's carrying this tuberculous bacilli sneezes out. It sneezes out its droplets, particularly around less than 5 to 10 microns of droplets, and they sit there on that. Major droplets carrying this bacilli will stick into your nose or into your upper respiratory tract or the upper bronchi. But those with less than 5 to 10 micrometer will reach to the terminal airways. It is very important that if you have just brushed off with somebody with a tuberculosis, or you have seen the person from distance, you will get TB. No, it's not necessary. There are quite a few contacts. You have to be in a very close proximity. You should be in a sufficient duration of their time. How infectious is the host? We'll talk about it later. And what is the shared environment you are? If you are, if any of your friend or any of the patient is living in, say, dormitory with a cramped up people, with 10 people staying in 10 by 10, then it becomes a problematic, and there is a likely that he's going to get that tuberculosis. What about the host factor? The host factor means the person who is carrying that bacteria and going to transmit it. So if the host is sputum positive or has got a cavitatory lesions, then it is very likely to transmit. Those who are sputum negative, culture negative, and non-pulmonary tuberculosis are not infectious. So tuberculous meningitis people, if you go, you don't need to put a mask on that because it's in the meninges. If there is no lung tuberculosis, if the tuberculosis is in a gut or urinary tract or in his bone or in his eyes or in his nails, heart, pericardium, brain, they're not infectious. Even if you put your head when touched his head with each other's head, it is not going to get transmitted like that. It doesn't work like that. So this is a very important when you are taking an infection control policies, that you don't have to keep putting a mask on everyone, because that creates a taboo, that creates an isolation, and that becomes a problem. Those who are sputum positive or those who are got a cavitary lesions, they are likely to be infectious and they should be isolated. They should be wearing the mask, and we should be wearing mask in front of them. Now, once this droplet reach into your alveoli, then the whole story depends upon how is your immunity, particularly cell-mediated immunity. Now, when these infections reach to a small children or an immunosuppressed person or a naive person, that naive person in the sense that any adult who has previously never been exposed to TB, when this person gets first exposed, they exhibit what we call it as a primary infection, right? In this primary infection, they may come out with various symptoms, cough, expectoration, and all those things. But they do not transmit because these bacteria are not shed from them, from the lung. They usually end up getting into a disseminated tuberculosis. They go through the lymphatics, they go through the blood. Very, very unlikely that with the primary infection, a person becomes an infective to other humans, especially small children, immunosuppressed people. Now, when I will come to what happens once the primary infection happens. When this tuberculosis gets reactivated, so the reactivation of the dormant bacilli into the body, or a person has already been previously exposed to the tuberculosis, he has had his primary infection, he is now asymptomatic, moving around, but the bacilli is still sitting there in some corner. He gets re-exposed or infection. Then the disease which gets manifested is called a secondary infection. In this case, most likely these people are sputum positive and or have developed some kind of cavitation depending upon the cell mediated immunity. So this is a very important classification and everybody needs to understand it. Am I clear? Am I clear, guys? Hello?
Yes, sir.
Any doubt till so far? Okay. So now when the person gets secondarily infected, or for that matter, sometimes in some cases primarily infected, what are the chances that these people become infectious, manifest disease, and are ready to infect other people? These all three criteria, we call it as an active tuberculosis. So what is when people call about, oh, this guy is an active tuberculosis, or this is not an active tuberculosis. When you call it as an active tuberculosis, these are the people who have received a second bout or secondary infection and now have manifestations for themselves and now ready to infect the other people. So what are the factors? So if the patients have been back to back infected in the recent year, that is less than 1 year, then there are some fibrotic lesions which are there. That means these lesions may be fibrotic at one place, but at some places they are continue to have those gone focus, gone complex, or granulomas. Certain comorbidities like HIV, silicosis, renal failure, diabetes, immunosuppressive treatment, gastrectomy, etc. All of these people are likely to become quickly active tuberculosis, ready to infect the other people. Malnutrition, underweight, and tobacco smoking. So what happens actually in a primary and in secondary? So let's see. So first you inhale, the alveolar, it reaches to alveoli. Now the alveolar macrophage takes it up. Now alveolar macrophage, as usual for any other bacteria, it will cause the internalization of the bacilli, and it will blow all the acids, it will blow all the cytokines, and it will try to kill the bacilli. But this doesn't happen in this bacilli. It does take up the bacilli, but bacterial factors, TB bacterial factors, particularly cell wall and other protein, they inhibit all the intracellular bacteria destroying mechanism. In particular, calcium pathway, cytokine secretion, polysomal fusion, all these three pathways which are responsible to destroy the bacteria and throw it into the lymphatics, it doesn't happen. Now, there is something called on the bacterial factor called as CatG gene. which protects against the oxidative stress. And in that gene, there are two proteins, ESAT gene and CPF10. These two proteins facilitate their expulsion from the phagocytes. So the bacteria not only resist the internal destruction and all the acid and all the cytokines which is secreted by the phagocyte, but it will also try to escape itself out. And this gene is particularly used for making BCG vaccine. So it doesn't cause much of a pathogenic effect. Now, while this bacteria resist inside the phagocyte, it will replicate and it will rupture the phagocyte, and then it will found a new place. So it will try to spread, and again the whole cycle keeps repeating. That again it will be taken up by few other macrophage, whether it's an alveolar macrophage, whether it's a blood macrophage, or whether it's a dendritic cells. All of them in the different places have a different name. Ultimately, they all are macrophages. They will try to take up, thinking that they are going to kill this bacteria. This bacteria is going to resist. With this CatG gene, it will try to push itself out. It will replicate. It will rupture the phagocyte and spread more. So this is what exactly happens, and that's the reason this bacteria don't die that easily. What happens with the host factor? So that means a person or the humans here. Once the bacilli enters the macrophage, it resists the phagocytosis, enters the cycle of lysis, re-entry, and multiplication. That is what we saw. Now, all the chemo attractors and the bacterial product. So once the bacteria bursts open, well, some amount of bacteria will die, some amount of bacteria will rupture, some of the bacteria will have its own apoptosis and they will die. So all these things, along with all the chemical cytokines which are secreted, they burst open from the phagocytes, and then they are all carried as a waste product into the local lymph node. Now remember, going to the local lymph node, it is expected that the bacteria are dead, only their dead products are there. But here, sometimes some live bacteria will also reach there. Now, in the lymph node, that's where the cell-mediated immunity and the humoral immunity gets activated, right? So, thus, the dissemination occurs very rapidly as the first line of defense is crossed, and immune activation occurs only after reaching the lymph node. So, once the patient has developed big lymph nodes, that means you rest assured that the initial first line of defense or the tuberculosis has already crossed. That means the tuberculosis is not recent, it has been there for last couple of weeks. The next classic, granuloma formation. How does the granuloma formation occur? Usually it takes 2 to 4 weeks now. Now, T cell macrophage activating response, it kills bacteria directly. Now, once these T cells, we saw that all this waste product and all the cytokines have reached to the lymph node, and in this lymph node, the T cells get activated. So T cells activated has two types of response. One is an immediate response, which will try to kill the bacteria directly, and the second response is a delayed type of hypersensitivity in which there is a tissue damage. So what happens is, try to understand, if you know that second year pathology, is that there are two ways an invading organism is killed. One is the organism is specifically targeted. Second is the surrounding whole tissue gets targeted, right? So in delayed type of hypersensitivity, the tissue damaging response occurs. It kills macrophages and tissues with the bacteria in it. Now, when these bacteria with the secretions and the macrophages, they are all get isolated, or I would say that they will get walled off with this delayed type of hypersensitivity T cells. They gather along them and they try their best to kill the bacteria along with the tissue inside. And this happens in the center. And once this central destruction occurs, it becomes like a cheesy material, like what we see as a pus. So what is a pus actually? Pus is not a bacteria actually. The pus is the dead bacteria and the WBC and all the things which we have. Similarly, the similar situation occurs in the center and it causes a caseation necrosis. Now, imagine this thing happening in the center and all the macrophages and the police and is coming gathering around each other to cordon off so that this doesn't go out. So this multiple accumulation of the macrophages and lymphocyte occurs with the destruction leads to multinucleated giant cells. And when this becomes a big, we call it as a granuloma formation. So the bacilli gets trapped inside this caseous necrosis and get inhibited. Now, because this small granuloma starts becoming big and big and big and big, the central portion gets devoid of more and more of oxygen, and the pH also drops. So this ideally is not a great situation for any bacteria. Bacteria should die, but few of these bacilli shows the resilience and remains dormant inside that granuloma, only to get activated later in the life when the situation arises or the environment permits. So now we know how the bacteria comes in, goes into the alveolar macrophage as a primary, then go to the lymph node, how these lymph nodes and everywhere else gets secondarily infected, becomes a granuloma formation, and then how the caseation necrosis occurs. So how does they manifest clinically? Now, clinically, because the point of entry is more of than not pulmonary, we get a primary pulmonary or a major presentation as a pulmonary disease. However, because the dissemination occurs through this lymph node, and through the lymph node, ultimately it goes back to the central vein. So all the lymphatics goes through, gets into a lymphatic tube, and then gets into the left side. It gets drained into the central venous system, and when it goes back again, it enters back through the right side of the heart into the lungs, and again it gets deposited in the lung, or sometimes it bypasses the lung and travels through and gets inside the systemic circulation to cause extrapulmonary tuberculosis. Now, this is not a rule for everyone, but remains as an atypical presentation in an immunocompromised patient. So the presentation is mainly primary disease and the secondary infection. So the primary disease, as we discussed, it's a first infection in children, non-endemic adults, or immunosuppressed. Presents as a cough, pleuritic chest pain, fever. It forms a Gons focal. So with all the pathophysiology I have explained, the first one, the regional lymph nodes to get affected are the hilar one, and this forms a big. So these patients will have this hilar lymphadenopathy with a caseous necrosis, and that we call it as a Gons focus. When this Gons focus is associated with a pleural reaction or in the lung lesion, we call it as a Gons complex. The other significant thing which you see in the primary disease would be the lymphadenopathy. Now, these lymph nodes, as we know, are in the various places in the body, whether hilar, it's a supraclavicular, cervical, axillary. There are multiple, and then the intra-abdominal, all sorts of places are there. Now, these lymph nodes, suppose they are in the hilar region or in other lung places, they may rupture, and then they release all these bacteria in the circulation. If they rupture, they may release in the lymphatics. If they rupture in the bronchi, they will release in the bronchi. So if they form that, then it spreads the infection. This may lead to a pneumonia formation, bronchial obstruction. Sometimes the lymph node becomes so big, it pushes the bronchus and causes bronchial obstruction. It causes ultimately reinfection in the local area, and again your same macrophage come together. They start destroying the central portion. Again, the caseous necrosis occurs, and at one point, when this destruction or this big chunk is becoming big and big and big with the central necrosis, at some point, at some place, it may rupture out. And when it rupture out, releases all the toxic material and the bacteria, it leaves behind a big cavity. So this might be the reason for a cavitation, and there is an active bacteria sitting at the wall of the cavity, and hence we get a lot of secondary complications with secondary to cavitations. And the second thing is when the healing occurs with the fibrosis, so it leads to a bronchiectasis. Now, when these lymph nodes or whenever the released bacteria gets into the circulation, it causes a hematogenous dissemination. And with this hematogenous dissemination, we get miliary disease, we get multi-organ involvement, meningitis, especially in children and in HIV patients. What happens in the secondary disease? So as I explained before, the secondary disease essentially is a reactivation of the dormant bacilli. Either your immunity has gone down to such an extent that this dormant bacilli, which was kept quiet and been protected by body, been protected by the caseating necrosis, gone focus kind of lesion, it gets activated, and then it becomes a disease process, or this person gets reinfected in context of previous infection. So now you know why the favored site is epiphysis, or the upper part of the lower lobe, because most of the time the air goes mainly in the upper part of the lower lobes. In epiphysis, because there is a more oxygen tension, they get favored. Now, the extent can, again, depending upon the cell-mediated immunity, it can be either small infiltrate to an extensive cavity. The spread of these secondary infection also occurs by liquefied necrotic content, which I spoke about it. They burst open via airways, bronchogenic spread, or cause a satellite lesion in the lungs. Now, once this spread occurs, they may have a different course. So either they get go in remission, healing occurs, fibrosis occurs, or they get into a severe pneumonia. So this is a secondary disease. So it may present as a severe pneumonia. In past, it used to call as galloping consumption, and it has a very high mortality, because by the time we realize this is caused by tuberculosis, because we are not used to see the tuberculosis coming as a severe pneumonia, right? So obviously, the first couple of days, weeks, we will not be giving any anti-tuberculous chemotherapy. We will be giving our regular antibacterial tuberculosis, other bacteria, covering other bacteria. So in that case, the mortality remains high. The last, sometimes if your immunity is good, your body will try to struggle, it will try to contend it again, it will try to burn, it will try to fibrose, and then it will have a chronically progressive debilitating course, where is the consumption of phthisis, it is called, leading to fibrotic changes, calcification, and bronchiectasis. Symptoms wise, these people will come with a diurnal fever, night sweats, anorexia, weight loss, malaise, cough. They may or may not remember whether they had a previous tuberculosis or not. They may or may not remember whether they had been exposed or not. So the past history will be very sketchy. Sometimes if the cavity has already formed, it's eroding, then it may come as a strict hemoptysis, or it may come as a massive hemoptysis. Now, there will be two reasons for a massive hemoptysis. Definitely look for a cavity, and in that cavity, either it's a blood vessel rupture, which is called as Rasmussen's aneurysm, or it might be secondary fungal infection, that is an aspergilloma inside the cavity. So pleuritic chest pain will be the associated with that. If rarely, if the patient develops a pneumonia or any ARDS, then they may present with breathlessness. The signs where the chest sounds would be can be normal, or it may be rales, rhonchi. Classic amphoric breathing we will see on the large cavity. On general examination, there will be a lymphadenopathy, pleural, cubbing, and wasting, because of if the nutritionally depleted person is there. Laboratory may show a wide range: anemia, leukocytosis, thrombocytosis, leukopenia, raised ESR, CRP, rarely hyponatremia. And these all are because of the inflammation, chronic inflammatory state that goes on, and or involvement of bone marrow. So this was all the presentation for the pulmonary tuberculosis. What is also important in the presentation is extrapulmonary, and we tend to get this more, especially in our continent where BCG vaccination is very widespread. So the most common would be a tuberculous lymphadenopathy, and it is the most common outside lung, especially in HIV and children. So it comes as a painless swelling in the posterior cervical or supraclavicular sides called as scrofula. They, on palpation, classically they may be appear as a rubbery, or they may as a matted contended mass. Diagnosis is usually with either FNSE, but I would suggest to go, if it's feasible, go for complete surgical excision biopsy, because if you give the full lymph node, the histopathologist, it will be easier to diagnose it. Microscopically, you see the granulomatous region with or without AFP, which you are aware of, and the culture positivity for this sample is very high, so 70 to 80%. In case of immunosuppressed, now remember, in immunosuppressed, your cell-mediated immunity will be less. So the delayed type of hypersensitivity is not as efficient as you will expect. So in that case, you won't find many dead bacilli. You won't find many in immunosuppressed, you won't find the granulomas much forming, and the bacilli won't be dead. So these granulomas are less organized, but there will be a heavy bacterial load. All the places where there are very heavy granulomas, that means the cells are more, and they are trying to kill the bacilli as much as possible. Bacteria try to they are trying to defend themselves. They are not completely washed out, but their numbers will be less. But in immunosuppressed patient, it is the other way around. So granulomas may not be visible, but there will be bacterial overload. The differentials in this case will be the lymphoma, metastatic carcinoma. I have never seen or don't know about this Kikuchi disease, Timur disease. I know about the Castleman disease. Continuing secondary TB, the second involvement is a pleural involvement. Now, in the primary, it is mainly the reactive. So, if you see a pleural effusion, it is mainly the reactive or parenchymal spread which comes as a pleural effusion. Classically, when you draw this, it is a straw color or hemorrhagic. It is an exudative. When you talk about exudative, you are talking about a high protein, normal or low glucose, pH is acidic, white cell counts are raised, and initial time it is always neutrophils, and later it's a lymphocyte predominant. Now we should be sending ADA levels. Now ADA, like a D dimer, has a negative predictive value. So if it's high, it doesn't mean anything, but if it's low, it can exclude TB. Usually, because this is a reactive effusion, you will have the fluid culture or AFP will be negative. Now, if you want to get confirmation, then you can do more of a pleural biopsy, and if you send for RT-PCR, then probably you will get it positive. Usually, they respond well to the chemo. But if you give steroids in these people, then it helps in quicker healing. Uncommon is an empyema. Now, having an tuberculous empyema is a big deal. So this happens if the whole cavity, which is full of this bacilli, gets ruptured. And when this cavity ruptured from the periphery, it will create a bronchopleural fistula, and it becomes very difficult to treat. So in this case, this culture and AFP will be positive. So if you get a positive culture or AFP positive in these cases, treat it like an empyema and look for the cavity and the bronchopleural fistula. Because the treatment here would be a surgical drainage. You can't just say that, okay, I will tap a little bit and steroid and then he will be done. No, chemo and surgical drainage with decortication, because there is a severe pleural reaction. The other common things you will see is the genitourinary. So many patients in India, especially the females, they are declared infertile, but they actually have tuberculosis of fallopian tube, endometrium. They present with infertility, pelvic pain, menstrual abnormalities, and it takes a while before the diagnosis is reached. In men, can come as epididymitis or chitis, and in both it comes as a UTI. Always suspect tuberculosis if the constitutional symptoms are there and if there is a pyuria and you don't grow anything. So usually 3 morning samples of the urine should be sent. RT-PCR will be a good test for them, and or if possible, urologist should help us to get a biopsy. Coming to TB bone and spine, and there are plenty, but I will be focusing mainly on the butt spine, wherein it happens because of the hematological spread or from adjacent lymph node in the paravertebral area. The classic presentation is that in between the two vertebrae. So one is the upper border of lower vertebra and lower border of the upper vertebra. They both get simultaneously involved. Whereas for the other bacterial and thing, it starts from the center of the vertebra. Here it is the opposite side. So two adjacent vertebra gets involved. It presents as a complications like vertebral fracture, where it comes as a kyphosis or called as gibbus, or if it's in the lumbar, it may have a psoas abscess. One of the most dreaded complication is paraplegia. Hip and knee, they usually come with a pain and diagnosed by the synovial fluid examination. The other thing you should be suspecting or should be knowing a little bit in a detail is a tuberculous meningitis. Now, from hematogenous spread is the commonest mode, and rarely it happens with the rupture of ependymoma. So there is evidence, there should be evidence of previous tuberculosis or current miliary tuberculosis. It's a slowly progressing symptoms with headache, mental change. Many in my career, I have seen quite a few patients who were taken to a psychiatrist. Some were elderly, some were teenagers who were taken to psychiatrists for abnormal or mental changes before they were diagnosed as tuberculous meningitis. They didn't had any other constitutional symptoms. If it's unrecognized early, slowly and gradually they worsen. They can get confused, they get neck rigidity, sometimes cranial nerve involvement causing cranial nerve palsies, stroke due to arterial involvement, and late complications such as hydrocephalus and intracranial hypertension. The diagnosis is with CT and MRI initially to rule out any space occupying lesion. Later CSF, which will be exudative with high lymphocytes, and PCR is sensitive. So CSF PCR, almost 80% sensitivity you will get it. Treatment is again chemo plus steroids. What is a miliary TB? So miliary TB will be interesting. It will be a hematogenous spread either through a primary or through the secondary. And again, same constitutional symptoms and cough. Now, because it is a hematogenous spread and it is a miliary TB, you may get hepatosplenomegaly and lymphadenopathy. Sometimes eyes show choroidal tuberculosis and they are pathognomonic, seen in 30% of the patients. You require a very, very high index of suspicion. On a first look, if you try to look the chest X-ray as you are looking now, I'm sure people will be just putting it under holding the X-ray in top behind the bed in the front of a tube light and saying kuch nahi hai. No, you are definitely going to miss that. See it properly under the view box. There should be a little bit under penetrated chest X-ray. If over penetrated, again it is not visible. You will see a small reticulonodular pattern across the lung fields in a miliary form. So this will be a diagnosis with a high suspicions. Other complications like interstitial infiltrates and pleural effusion may also be seen. Usually, because it's a hematogenous spread and it's a miliary, sputum is negative. Most of the time they have a dry cough. They don't produce any sputum. So if it's a miliary, don't expect your sputum to be positive. Hematologically, as I said, because of the hematogenous spread, it will have either monocytosis or monocytopenia or bi or pancytopenia. They can come with a D-range LFTs, particularly a high alkaline phosphatase. The tuberculous skin test, that's the Mantoux test, which we say, they are negative initially, but then later become positive, and this is because of the energy. Now, ball and transbronchial biopsy will have a lot of culture positivity. In a liver or bone marrow biopsy, you may see the granulomas based on what your suspicion is. If it's not treated, miliary tuberculosis is very lethal. And remember, it responds well to chemo. And in this case, miliary case, you do not give steroids. This is one thing which you need to remember. Then it is said that tuberculosis involves right from your hair till your nail. So there is a wide range of things which, because of the hematogenous spread, most of the time they are accompanied with either most of the time they are accompanied with the pulmonary involvement. So the secondary TB we get from gastrointestinal to gut, liver, spleen. In pericardial tuberculosis is very well known. You have eye complications, you have ENT complication, nasopharyngeal involvement. Skin is also not spared. There are classical lesions like lupus vulgaris, erythema nodosum. You get mastitis. Adrenal TB is also known. I had a few cases where patient comes with a hypotension, with a disseminated disease, an adrenal TB, and then we have a congenital TB. So, how will you diagnose? Clinical suspicion should arise right with constitutional symptoms, his past history, his area, the regional history, where he's coming from. All those things should have a high suspicion. First suspicions many a times comes while you're looking at a chest X-ray. You're looking at a chest X-ray of something for some cells or for breathlessness or some routine chest X-ray, and then you start having a suspicion. So classically, you see some upper lobe infiltrate with associated cavity if it's in a delayed situation. In an immunosuppressed elderly or children, there is a wide presentation. Right from normal chest X-ray to full-blown pneumonia, ARDS, hilar lymphadenopathy. There maybe in children they say that it's an upper part of the lower lobe infiltrates are commonly seen. The next thing for the diagnosis is to look at the bacilli, that is the acid-fast bacilli. So you need a proper sputum with a cavitatory where the sputum positivity you're looking at, or the tissue sample, particularly FNAC or the lymph node, or you have a ball, or you have a gastric or gastric biopsy. Everywhere you have to look into it. Stains, Ziehl-Neelsen was the previous one, but now with advent of technology, RMI and rhodamine staining with the fluorescence microscopy or light emitting diode microscopy are used for the faster recognition. The sensitivity of fluorescence microscopy is much higher than the ZN stain. Usually 2 or 3 morning sample or the tissue sample is to be morning samples of urine or sputum should be taken. When you're sending a tissue sample, this is very important. When you're sending a tissue sample, usually they're sent in a formaldehyde for making slides. But if you are suspecting you want to do it for the culture or you want to look for AFP stain, do not send a sample in formaldehyde. Otherwise, it gets destroyed. Bacteria bacilli gets destroyed. What we are now used to here, instead of culture and AFB thing, see, even though gene expert is there, still AFB is a gold standard, and I would highly recommend to at least do a Ziehl-Neelsen stain or fluorescence staining along with gene expert. It has its own implications, because if you have those bacteria culture grown, then you can be better off with the sensitivity pattern also. So nucleic acid has changed or revolutionized the diagnostic capability, and the sensitivity has gone up almost to 98%. It detects not only tuberculosis, but also looks for the resistance in the rifampicin in less than 2 hours. It is recommended as an initial test for children immunosuppressed, where you know that the sputum positivity is going to be less, or you're suspecting multi-drug resistance. Samples might be any, but mostly preferred any sample you can send it for a gene expert. However, CSF and non-respiratory specimen, that is where you know for sure that you are not going to see AFB. If you see AFB, that's that's much bad, but less likely to be there. And then those people you can those samples you can send it for a gene expert. We spoke about the microbacterial culture, which is very long taking. Then we have a drug susceptibility testing, which we can discuss it later. Radiographic testing like CT scan, MRI, and ultrasound. Its characteristic features help us to suspect the tuberculosis. It doesn't give a definite diagnosis. Some patterns are there, like fern pattern is there, or inverted Christmas tree pattern is there. That is there in the CT scan, which we look for the tuberculosis involvement. They also help us in looking at the complications, particularly in the head, like hydrocephalus. Ultrasound abdomen, look for the liver, spleen, looking for the granulomatous lesions. They are, well, space occupying lesions rather than a granulomatous regions. They are useful. Now, all these things we spoke about was for the diagnosis of a proper primary or secondary infected TB or a patient who is sick, who has come out. But how do you diagnose whether this patient has got a latent TB, that is the tuberculous bacilli sitting in his body, or and that means he's been exposed to tuberculosis. So initially it was, and why it is important for us? It is less important for our endemic people because we are actually bathing in the tuberculosis. So we don't know who is spreading, and our national program has already given us the BCG. But this is more common for those who are coming from non-endemic area. So the initial historic one was the old tuberculin test in 1891 when Robert Cox gave in 1891, and later it was much more purified. We call it as a purified protein derivative in 1932. So basically what it tests is the T cell response inside the skin. So whether antigenic, so these are the tuberculin antigens, so the proteins of the tuberculosis we inside the skin, and whether these T cells respond to them or not. And they are not the sensitized T cells which are circulating, so they are a bit different. So the advantage is it is easy to perform. There is no lab. So if somebody is exposed previously and all his T cells are carrying the information, then the T cells in the skin would also respond accordingly. It is easy to perform. Anybody can perform. No lab is required. The problem with it is very crude test. It cannot differentiate whether the person is actually having tuberculosis now or it had it in past, or it's just a latent. It doesn't differentiate between Mycobacterium tuberculosis or non-tuberculous mycobacteria, because all the proteins which are commonly shared are injected. It also cannot differentiate whether it's a post-BCG vaccine person is there or not. There is something called as boosting. That is, as in if you give the this test 2 times in a person in a short period of time, then whether it's the effect of the previous injected protein, or this is true conversion, that means he's got a post BCG and he's got a true conversion, we cannot tell. So it's a very crude test which is now less and less being performed. What came later was the interferon gamma, which we famously call it as a quantiferon gold. So what it does, so quantiferon gold actually measures the release of interferon gamma from the T cells in response to a highly specific TB antigens. We saw that, right? On cat gene, we have got ESAT6 and CFP10. These are the 2 TB specific antigen which are extracted and then they are injected. And they're measured again, not injected, they're measured again. And we see in the blood sample, the T cells, whether they release this interferon gamma. So 2 assays, that is the quantiferon TB gold assay and T-spot prototype. So it came up some time back with a bang, and everybody started saying that, oh, this is the best test available, and this is the versatile, and this is much better than skin test, these and that, and blah, blah, blah. However, however, this test required drawing blood properly, and then there were laboratories which were there to be sent, and then they used to do this in the laboratories, and a laboratory was essential for this. So this becomes a disadvantage because many low or medium income country doesn't have laboratory, and to have the setup just for this is an expensive affair. So basically it became an expensive TST for a high income countries, so that they feel good about it. Advantage was there was a logistical convenience. You just have to send some blood somewhere, and the patient need not go. There was no better information we are getting over the TST. So essentially, WHO in the end ended up saying IFG, that is quantifier and gold, are recommended in high income countries, while TST in the low and middle income countries. So both of them are not much difference, to be very honest. So, or we call it as a glorified TST. So this was on the diagnosis aspect of it. So let's go a quick overview on the treatment aspect. We all know, I'm not going to go in much in detail. We know the first line, we've got 4 drug ATT. So these are the drugs. Now remember, this bacilli is a very resilient bacilli. It doesn't get killed with a single antibacterial. So we need a group of drugs, and we started off with this 5 primary group of drugs, which is still we are using it. It has a fixed dose, definite dose. Somebody ask any questions? You can stop me from this thing. Last slide, please. Yeah, I'll do that. I'm not very far away from finishing. Yeah. So this INH, rifampicin, pyrazinamide, and ethambutol, you need to know about its dosage and its side effects. The second line, we had a list which got a fluorochloronons, then injectable aminoglycosides. We have capreomycin, ethionamide, cyclosporin, and PAS. Now these were the second line treatment recommended by WHO if there is a resistance going on. Now, there was also sensitivity shown in past to linezolid, amoxicillin, clarithromycin, and meropenem, but they are no longer recommended, or it should not be used for a treatment of tuberculosis. There are 2 new class of antibiotics being introduced, that is deraquinolin, bedaquinil, and nitroimidazole, delamanide. So these are the 2 new class of drugs. They are extremely restrictive medicines, and they can be now available only on the from the government hospitals only. As you know, there are 4 drugs to be taken. So everybody has its own regime, and each state has a state in the state of the patient will have a particular regime. So new smear or culture positive, you have this 2 months of intensive phase and 4 months of continuous phase. Then we have different for culture negative case. Then we have for pregnancy. We have for the relapses. These are all standard guidelines. There is nothing more to add or explanation to be given. When I'll talk about the other the regimes in the details, but for the failures and for the resistance and for the XDR-TB, there are the special precautions you need to take, that we will talk it later in the next class. So the failures, you need to be tailoring about it. You need to define the failures, you need to define the resistance, you have to define the MDR and XDR. So for the next, we are going to talk about the drug resistant regimes. Then we'll talk about the prevention strategies. Then we'll talk about the special situations. And then we'll talk about the TB and public health. And we'll also touch upon the non-tuberculous mycobacteria. So that's where I will stop today. It's already 1 hour, 10 minutes. Any questions? Any question, guys?
Hello.
Yeah.
Sir, once BCG given, that confirms a lifelong immunity to patients, or we have to give frequently this BCG vaccine?
No. So okay. So let us try to understand what BCG is given. So By the current standard, you would have now understood that when the patient is naive, that is, he's never exposed, like small children, elderly, or those people who are immunosuppressed. When these people get or naive, that means he has never been exposed. When these people get this bacteria, it rapidly disseminates. It causes destruction in the lung. So the havoc, the point of entry is in the lung, where the cavity formation occurs, and that's where the maximum spread occurs, right? So out of pulmonary tuberculosis and non-pulmonary tuberculosis or extrapulmonary tuberculosis, pulmonary tuberculosis is the one which is responsible for the spread. So what these people did was, if we give these people BCG vaccine, that means the BCG vaccine is the protein of the tuberculosis. So the T cells or the immunity of these person or the whole cohort of the people or whole country, kids of whole
Yes.
country, will have a sensitized T cells for rest of their life.
Okay.
Okay. Now, once you have a sensitized T cells, okay, that will create a kind of, every person who is later exposed to TB will have a secondary type of response rather than the primary type of response, correct?
Okay.
Now, in secondary type of response, the pulmonary involvement is very, 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 very less. It is mainly the disseminated, it is mainly the tuberculous meningitis or extrapulmonary tuberculosis, right? So in this way, that person become less infectious. So coming to the answer to your question, BCG vaccine is not preventing you from getting the tuberculosis disease. You may get a tuberculosis infection, you may get tuberculosis disease. It will be mainly a non-pulmonary tuberculosis, so that you do not infect to other people.
Okay.
And once you give it, it becomes a lifelong thing.
Lifelong.
Okay. Unless you
Okay, sir.
undergo a bone marrow transplant or you undergo something like that where it's a drastic changes in the immunity, that's different, but that still doesn't qualify for it. Okay.
Okay.
Sir,
Okay.
sir, good evening, sir. I'm Dr. Rituraj De. I
Yes,
want to put some information on this, sir, on this BCG vaccine, actually, sir.
correct.
I'm a MD in community
Welcome.
medicine, and it
Oh,
was
fantastic.
done, the actual BCG trial was done in Chingalput. It was in South India, and it was seen that the BCG only prevents the two type of childhood tuberculosis. That is, one is the miliary tuberculosis and another one is the tubercular meningitis, and it is only given within 1 year of life. So after 1 year it is of no use. Basically
Okay.
that study shows that type of data, that Chingalput study, and it actually prevents only two type of tuberculosis infection that I've told right now. And other than these, no other infection, no other type of infection by the tuberculosis is being prevented by the vaccine, actually.
Okay, that was an information for me because I was under the pure, honestly, with the infection as whatever the textbook says, it tries to prevent the pulmonary tuberculosis and its complications. As
Yeah,
again,
that is the miliary that is the form of miliary tuberculosis in childhood only, and
okay,
and
but
the other form, that is the tubercular meningitis, only for the children, not for the adults.
okay, no, okay, right, tuberculosis. But does it prevent pulmonary tuberculosis in adults?
No, no, sir. There is no protection on pulmonary tuberculosis on adults, provided there is a vaccine, BCG vaccine given. So there is no such data.
Okay, right. So that would I stand corrected on that. Thanks, Rituraj, for that. So
Oh,
that's
it's
the
okay.
advantage of.
It's an honor,
Then
sir.
of course, no. So see, you are a practical person on the ground who's with the community medicine that has much more better information than definitely I would be as a physician. I would be doing it. But
So
yeah, that's all
I
right.
can share you the study details. That is known as the Chingalput study. It
Single
was
put study. I will.
the large scale study. Only one large scale study was done with the BCG. That is a Bacillus calmette guerin vaccine. That is a
Okay.
live form of vaccine, BCG vaccine. Uh,
Okay. That's
So only
great.
one large scale study we have, and that data shows this type of picture.
Okay, that's Chingalpur. I will go through that. That's fantastic.
Yeah, sure, sure, sure,
Good
sure.
information. Thank you, Rituraj.
Okay, sir. Okay, sir.
Thank you, sir. For this session, we shall conclude.
Yeah, go ahead, Padma.
Thank you, everyone. We'll be scheduling the class soon. Thank you. Thank you, sir. See you,
Thank you.
Mali.